Hello dear students, myself Dr. Maddineni Srinivas. So in this video we are going to look at the psoriasis topic from a very high yielding one-liners aspect. So let us begin our discussion. So psoriasis. Regarding etiopathogenesis, you need to remember that this is having important association with HLA-CW6. And in the immune mechanism, T cells are going to play a very key role. This is an autoimmune disorder, if you remember, because of which ultimately there is going to be a keratinocyte hyperproliferation. And there are various triggers for psoriasis. So what are they? Trauma, like for example Koebner's or Keebner's isomorphic phenomenon, and gutted psoriasis, if you remember, it is associated with the streptococcal infection, and stress, alcohol, smoking also can be triggering factors, and medications, if you remember, the painkillers, NSAIDs, lithium, beta blockers, all of these can trigger psoriasis. And what are the important cytokines associated? So you need to remember tumor necrosis factor alpha, interleukin 17 and interleukin 23. And why is it important to remember all this? Because there are certain biologicals which will act by reducing these cytokines. So coming to the clinical features, remember very important term which you need to remember is silvery white micaceous scales. Yes, they are going to be present on erythematous plaque. And what are the common sites? You need to remember extensor surfaces, elbows, knees and lumbosacral area. And there is one important named sign which is Auspitz sign, which is pinpoint bleeding upon the removal of the scales due to the dilated dermal blood vessels. And if you remember, this was also recently asked, and you can remember the Grattage test can be the other name which is used instead of Auspitz sign. So what is Koebner's phenomenon? Appearance of the new lesions at the sites of the trauma or injury is called as Koebner's phenomenon, and this is also seen in the lichen planus and also vitiligo along with psoriasis. So what are the important nail changes? This is also important question. So remember, the most common nail finding is going to be the pitting of the nail, which is described as deep, irregular and coarse pitting. And we can also see the separation of the nail plate from the nail bed, which is called as onycholysis. And the most characteristic or pathognomonic sign for psoriasis, which is oil drop sign, which is also called as salmon patch. Subungual hyperkeratosis can also be seen. And what are the various types of this psoriasis? So remember, the most common variety is called as psoriasis vulgaris, which is also called as chronic plaque psoriasis. And like I have already told you in the triggering factors, if there is a child who is having the streptococcal infection, sore throat, then there can be a formation of the raindrop like lesions over the body, which is called as gutted psoriasis. Pustular and erythrodermic psoriasis, remember, these are due to the sudden steroid withdrawal in the psoriasis patients. And in the pustular psoriasis, obviously there are going to be pustules which will be present over the body. And if it is generalized form, we call it as von Zumbusch type of pustular psoriasis. And if this pustular psoriasis, generalized pustular psoriasis, occurs in a pregnant woman, then we are going to call it as impetigo herpetiformis. And in the erythrodermic psoriasis, just remember, the body is going to become red in color associated with scaling, almost involving more than 90% of the body surface area. Okay. And there is inverse psoriasis, which is very simply, it is also called as flexural psoriasis, because psoriasis usually affects the extensors, but if flexural areas are affected, then we call it as inverse psoriasis, because it is inverse of the usual routine psoriasis. And I hope this video, you are enjoying this. If you at all it is helpful, please do hit that like button. Okay. So next is psoriatic arthritis. Remember, this psoriasis is associated with inflammation of not only the skin but also the joints. So we call it as inflammatory arthritis, and it is a seronegative arthritis, and up to 30% of these patients can be involved, where the classical joint which is involved is distal interphalangeal joint, and there are 6 types of them, but you can remember the first thing, which is the asymmetrical oligoarthritis, is the most common presentation of the psoriatic arthritis, and also there can be most severe form which is called as arthritis mutilans. Coming to the investigations, remember, skin biopsy findings we'll see in a minute. There it is going to confirm the diagnosis. And yeah, PASI score, it is not very important, but maybe it can be a psoriasis area severity index, is a scale or grading system used to tell the severity of the psoriasis. Coming to the lab you can do ASO titers in the case of the gutted psoriasis, and liver and renal function test have to be performed because the medications, methotrexate, acitretin, which we give, they can cause derangement of this function, liver and renal function test. So in the radiography, I hope you all do remember that pencil in cup deformity can be seen on X-ray. Coming to the histopathology, this is very important now. So we can see from the stratum corneum, you can remember in that order, we can see parakeratosis, which is retention of the nucleus in the stratum corneum, and we can see the presence of the neutrophils in the form of a collection in the stratum corneum, which is called as Monro's microabscess, and also we can see the thickening of the stratum corneum, which is called as hyperkeratosis. And coming to the next layer, that is stratum granulosum, we can see absence or reduced thickness of the stratum granulosum, which is hypogranulosis. Next, we are going to see the acanthosis. So what is this? Basically, we are going to see the elongated rete ridges and stratum spinosum thickening can be noted. And this elongation of the rete ridges, it is also called as test tube appearance or camel foot appearance. And there is a collection of neutrophils not only in the cornea but also in the stratum spinosum. We call it as spongiform pustules of Kogoch. So there will be a suprapapillary thinning, and this is the reason for the Auspitz sign which we clinically see. And in the dermal papilla, we can see the dilated blood vessels. So coming to the management and the treatment, topical systemic phototherapy, these are the broad therapies which we are going to utilize. So the corticosteroids are going to reduce the inflammation. These are the first line for mild to moderate type of psoriasis. Vitamin D analogs, like for example calcipotriol, it is going to regulate the keratinocyte proliferation, because all the problem here is the keratinocyte hyperproliferation, and also it is going to normalize the differentiation of these keratinocytes. Vitamin D analog calcipotriol. Coal tar preparation, basically it is an anti-proliferative and also anti-inflammatory in action. Diethranol or anthranil, it is going to inhibit the DNA synthesis, thereby reducing the keratinocyte proliferation. Next is phototherapy. We are going to use ultraviolet rays, basically ultraviolet B rays, and in the very narrow range we are going to utilize this 311 plus or minus 2 nanometers. It is called as narrow band UVB or NB UVB. It is also called as NB UVB. Next is the combination of the psoralen with UV ultraviolet A radiation. We call it as PUVA therapy. In the systemic, you can remember methotrexate. Basically, it is an antimetabolite. It inhibits the DHFR, dihydrofolate reductase. And we have to monitor the liver function test. And in the acid retin, you can remember it is a systemic retinoid, and this is useful particularly in the cases of pustular psoriasis and also erythrodermic psoriasis. So cyclosporin, calcineurin inhibitor, and this is having a rapid onset of action, but the problem is that it is a nephrotoxic medication. Methotrexate and acitretin, both of these have the problem that both of them are teratogenic medications. Okay, remember apremilast, it is a phosphodiesterase 4 inhibitor, and this is recently being used very commonly in the patients of the psoriasis and also in the pemphigus vulgaris. And remember, in the systemic treatment, systemic steroids are contraindicated in the psoriasis patients except for two conditions. What are those conditions? If a pregnant woman develops pustular psoriasis or erythroderma, then we cannot use acitretin or methotrexate. Then in that case, we are going to use steroids as the drug of choice for the patients of psoriasis. There are various biological agents. Okay, you can just remember few of them. Tumor necrosis factor alpha inhibitors, etanercept, infliximab. Okay, interleukin 17 inhibitors, secukinumab, brodalumab, ixekizumab. Brodalumab is basically interleukin 17 receptor. It acts on the receptor. Interleukin 23, you can remember ustekinumab. Okay. And what are the lifestyle modifications? So you have seen in the etiopathogenesis, there can be some triggers like for example smoking and alcohol. So we should ask the patient to reduce them. And in the weight management, remember obesity can exacerbate the psoriasis. And also psoriasis, it is associated with the metabolic syndrome also, if you remember. So we can advise the patient to reduce the weight. And remember, yeah, there is a rebound phenomenon. This is the reason for the sudden systemic steroid withdrawal producing the more dangerous or severe form of the psoriasis, which is erythrodermic psoriasis and also the pustular psoriasis. Okay. Next, just few one-liners again. Voronov ring. So it was not asked, that not much important. So there is going to be a small hypopigmented ring or rim surrounding the psoriasis lesion, which is called as Voronov ring. And if there is a patient who is having the features of the seborrheic dermatitis and also psoriasis, we call it as psoriasis. So guttate psoriasis, usually it is going to resolve spontaneously, but it may progress to chronic plaque psoriasis. And like I've already told you, Koebner's isomorphic response, it is going to be associated with psoriasis, lichen planus and vitiligo. So I hope this video was helpful. If it was helpful, please do hit that like button. And if you are new to my channel, please do subscribe. And I'm making these kind of one-liners on related to all the topics, okay? So I will leave the link for the playlist in the description, also in the first comment. You can check that out and you can watch all the videos, whatever maybe the platform you are following psoriasis from. You can watch this video and you can revise this, and also whatever platform you are using for dermatology, entire dermatology, you can watch all these playlist videos as a quick summary, recap or rapid revision of all the dermatology. I will try to make all the chapters available in my YouTube channel. So please do subscribe and also share this among your friends who might be requiring to watch these quick recap videos if this was helpful for you. So comment if you have any more doubts or queries or any other additional points you want to tell, and if you are having any more suggestions, you can leave the suggestions in the comment section. So thank you so much for watching the video till this point. Happy learning. All the very best. Sarvam Sri Krishna Pranam Sarvai Jana Sukhina Bhavantu. Thank you so much.